Okay. Okay. Good afternoon, everyone. Now we are going to start our session on pediatric related to the pediatric toxicology. This is organized by KidToxLK, Pediatric Information and Research Center, Faculty of Medicine, University of California, in collaboration with Sri Lanka College of Paediatricians. I am Professor Namal Rathnayake from Department of Pharmacology, Faculty of Medicine, Sabaragamuwa, University of Sri Lanka. Today our topic is unexplained metabolic acidosis, recognizing poisoning mimickers. Today we have three speakers, Professor Kavinda Dayasiri, Dr. Yashoda Samarakoon, and Dr. Imalka Kankanarchi. Today our first speaker is Dr. Yashoda Samarakoon. She's a registrar in Paediatrics, Colombo Teaching Hospital, Ragama. She will do a case presentation related to the topic. I will invite Dr. Yashoda. Okay.
Good afternoon, all. Thank you, sir, for the kind introduction. Today I will be presenting 1 year and 5-month-old. Previously healthy child was presented with persistent drowsiness for 1 hour duration to the ETU of Colombo Teaching Hospital, Ragama. And history was taken from the mother, who was educated up to O-level. And on the day of admission, child woke up at around 3:30 a.m. and cried and vomited. And following that, child remained irritable until 7:30 a.m. Around 7:30 a.m., child got out of the bed with an few minutes. Last meal was taken at 6:30 p.m. on the day before admission. 3 days prior to the admission. Yes, and this is regarding 1 year and 5-month-old child who has presented with the episode of drowsiness for 1 hour duration to the ETU of Colombo North Teaching Hospital. And history was obtained from the mother. According to the mother, on the day of admission, child woke up at around 3:30 a.m. and child had cried and vomited. And following that, child remained irritable until 7:30 a.m. And around 7:30 a.m., child got out of the bed with an unsteady gait and then became unresponsive within few minutes. Until the day before admission, child had been well and last meal was taken at 6:30 p.m. on the day before admission. And child had been treated for the upper respiratory tract infection 3 days prior to this admission. Treated with fexofenadine, theophylline, and cetirizine. And there are no respiratory symptoms on the day of admission, or no recent history of head injury or recent trauma, and child did not have any fever or other systemic symptoms. And no swelling, no insect bite, or no history. She's on oxcarbamazepine and clobazam. Grandmother is a patient with type 2 diabetes mellitus and hypertension and dyslipidemia. She's on metformin, gliclazide, sitagliptin, losartan, amlodipine, and atorvastatin. In the past medical history, child had been managed for the milk aspiration at day 29 of age and managed for the allergy reaction at 1 year and 5 months of age. And it was 2 weeks back to this admission and trigger was not identified. No other past medical illnesses or similar unresponsive episodes. And past surgical history was not significant, and allergy history, as mentioned above, child had an unknown allergy reaction for the unknown trigger, and no other documented allergies. In the birth history, this child was the firstborn to non-consanguineous parents, and it was unplanned pregnancy, and mother was on treatment for the epilepsy, and she was on oxcarbamazepine and clobazam. no other antenatal complications, and child delivered via normal vaginal delivery at term, and his birth weight was 2.35 kilos and no postnatal complications. Immunizations were up to date, vaccinations were up to date, and developmental milestones were age appropriate. In the family history, there were no history of metabolic diseases or neonatal deaths, and social history part, mother is a housewife and father is working at a private sector, and both of them were educated up to O level, and they are from the middle class socio-economic background, and grandparents also living in the same house with this child and parents. Examination on admission, this child was afebrile, and he was not pale, and his growth was average for the age, and there was no facial edema or skin rashes. And apart from the neurological examination, other examination parameters maintained within the normal range, and GCS around 7 out of 15, I1, verbal 1, and motor 5. Bilateral pupils were pinpoint, and pulse rate 112 beats per minute, and pulse volume good. Blood pressure 87 by 56 mercury millimeters within 50th to 90th centile, and capillary filling time less than 2 seconds, and peripheries were warm. Respiratory rate 28 cycles per minute, and lungs were clear, and air entry equal, abdomen was soft, and 2 centimeter hepatomegaly was there. And on admission, in our initial investigations, all the investigations were normal except BBG, capillary blood sugar, and the urine ketone bodies. Urine ketone bodies 3 plus, and CBS 56 milligram per deciliter. And the VBG, there was metabolic acidosis with increased anion gap of 22. And urine for multi-drug test panel, we did, and it was negative for the opiates and propoxyphene, barbiturates, benzodiazepine, and tricyclic antidepressants. With these investigations, we resuscitated this child with 3 ml per kg, continued with 5% dextrose infusion. After 1 hour, with this dextrose, 10% dextrose bolus, CBS has improved from 56 to 136. And after 1 hour, GCS also improved. And GCS improved to 15 by 15, and bilateral pupils 2 reactive, and other parameters remain within the normal range for this 1 hour. After that, child was stable, child was transferred to the pediatric ward, EEG as well, and which was normal sleep EEG, and non-contrast brain was also normal. And during the ward stay, child had developed second episode of hypoglycemia. It was around 3 hours later from the initial recovery, and CBS was 59 milligram per deciliter, and another bolus of 10% dextrose in 0.9 sodium chloride started. And CBS improved from 120 milligram, from 59 to 120 milligram per deciliter. After this second episode, child was on 10% dextrose infusion for 12 hours. And as child has clinically improved, fluid was cut down to the 5% dextrose infusion, and CBS was maintained within normal range thereafter, and no another episode of hypoglycemia. And as there was persistent metabolic acidosis in the VBG, bicarbonate correction done. Initial bicarbonate was 11 millimole per liter, and corrected with 1 ml per kg bicarbonate 1-to-1 dilution, and bicarbonate improved from 11 to 18 millimole per liter, and with that VBG shows improvement in the acidosis. In the summary, this is 1 year and 5-month-old child presented with the episode of drowsiness following vomiting and unsteady gait. An investigation revealed recurrent hypoglycemia with high anion gap metabolic acidosis. And child improved with dextrose and bicarbonate corrections, and neuroimaging and EEG were normal.
Okay. Okay. Thank you, Dr. Yashoda, for your case presentation about the child with poisoning child.